Hello, everybody. Good evening or good morning, afternoon and evening to everybody. I know there are alumni joining us from all over the world this evening, which is fantastic. A colleague of mine has just told me that 26 countries are joining us today, so that's absolutely wonderful. My name's Lisa. I'm the Regular Giving Officer in the Darrow team here at the University of Leicester and your host for tonight's event. So thank you for joining us for the latest Festival of Change online talk. It's wonderful to welcome so many alumni and friends from around the world this evening. So our speaker tonight is Dr. Elpida Vounzoulaki, born in Greece and a fellow alumna and postdoctorate epidemiologist at the Leicester Real World Evidence Unit within the Diabetes Research Centre. Her research focuses on cardiometabolic complications, women's health and real-world epidemiology. Elpida will be discussing gestational diabetes, a condition that develops during pregnancy and typically resolves around birth. Before we begin, Elpida's talk, please feel free to keep your video on, but please mute your microphone so we can hear all of the talk clearly. If you need assistance, the alumni team will be on hand to mute you. Also, we'd love to hear your questions, so please post them in the chat and we'll address as many as possible during the Q&A at the end of the talk. So now please join me in welcoming Dr. Elpida's presentation, which this evening is entitled Gestational Diabetes and Maternal Health, Building a Healthier Future. Thank you.
Hello everyone, just checking I'm sharing my screen. Is everyone able to see my screen?
Yeah, we can see your screen.
Okay. So hello everyone, thank you for joining today. So nice to have so many of you. Some of you, sorry?
Yes, like you want to have a conversation about something. You're the most annoying.
I'll just share it again. Hi everyone, thank you so much for joining today, and it's so nice to have so many here joining here tonight. Some of you already know, some of you I don't, but it's nice to virtually meet you since you're joining today. Thank you for the lovely introduction. My name is Elpida, just again to say to everyone, I work at a team called the Leicester Real World Evidence Unit within the University of Leicester that is based within the Diabetes Research Centre. And today I'll be talking about gestational diabetes, and I'll get to talk about in more detail what gestational diabetes is and how it affects maternal health. And we'll be focusing on how gestational diabetes can be an early warning sign to improve long-term maternal health. So first I'll start with some introductions and I'll tell you about who I am, how I got to the University of Leicester and what I'm doing today. My story starts back in Greece a few years ago when I started doing my degree in nursing, and that was the first time I actually worked in clinical practice as a clinician, something that is very valuable to me today as an epidemiologist, as I remember the days I used to work in the hospital and have direct contact with patients. That was the first time I actually worked, and I had patients with diabetes, where I actually had the opportunity to chat with them and see how they experience diabetes, what the concerns are, and how they're living with the disease. And moving on, I did a master's in medical research that was still in Greece, where I was assigned a project on gestational diabetes by my then supervisor and one of my mentors in my research career. And that was the first time I actually had the opportunity to work in the field of gestational diabetes and realize why it's so important. So combining my clinical background, the experience I had with working with patients, and my master's dissertation, I realized that doing research is something that I want to do as a career. It's somewhere where I want to be in the future. And while working in clinical practice, you can benefit individuals that actually know your name. With research, you can benefit thousands or millions of individuals across the world. And I think that is fantastic. So I went on and applied for a PhD at the University of Leicester. And after receiving a studentship, I moved from Greece to the UK. Very different environment, very different weather, I can say as well. And that is how I got to where I am today. I finished my PhD and then I moved to a job post. Currently, I'm a postdoc epidemiologist within the Leicester Real World Evidence Unit at the Diabetes Research Centre, and I've been working here for a couple of years now. I've recently also received a fellowship award from the NHR called the Development and Skills Enhancement Award, which is an award that gives you the opportunity to develop skills within a specific field. So my field is epidemiology, and particularly where I'm looking to go with this award is that I'm extending my current skills and I'm developing knowledge in the field of machine learning and AI, which is a developing field, particularly in the area of health data science, receiving training from institutions across the UK and the world, and also receiving mentorship and developing collaborations. So this is where I am today, and I'll move on to talk about the research. So before I talk about the research, I'll give you some definitions, as I'm aware not everyone who's joining today is either a clinician or a researcher that's working in the field. So just a bit of terminology before we get started. So gestational diabetes, which we've already mentioned, but we've not really explained, is a condition where we have very high blood glucose levels or high blood sugar levels during pregnancy. And the very interesting thing that happens with this condition is that women get diagnosed with this condition during the second half of pregnancy, but once they give birth, their blood sugar levels return to normal. So you can say the condition resolves after giving birth. But gestational diabetes is not type 2 diabetes. Type 2 diabetes, which more of you might be aware of, is a chronic condition where we have very high blood glucose, blood sugar levels, and type 2 diabetes does not resolve. So once diagnosed, a patient carries the diagnosis for the rest of their lives. Why do we talk about gestational diabetes alongside type 2 diabetes? I'll move on to talk about this next. So how do they relate to each other? So we said that gestational diabetes is a condition that goes away after giving birth. So we say it's temporary. But women who were diagnosed with gestational diabetes during pregnancy are more likely to develop type 2 diabetes in the future. And this is where my research comes in. So based on a study I did a few years ago, it is estimated that women who were diagnosed with gestational diabetes during pregnancy, despite the fact that the condition resolved after they give birth, are almost 10 times more likely to develop a diagnosis of type 2 diabetes compared to those who were not diagnosed with gestational diabetes. So over 10 times more likely is quite a high risk. So let's see, we saw what gestational diabetes does to your health briefly. We're going to be talking about it in more detail later. But what happens after the diagnosis? So someone's been diagnosed with gestational diabetes during pregnancy, they've given birth, the condition resolved. What does the research say? So one thing we've mentioned already is that gestational diabetes increases the risk of type 2 diabetes in the future, and there is an established relationship between those two. But gestational diabetes also is associated with other conditions. So you can see, based on latest research, gestational diabetes is a precardiovascular disease state, which means that having gestational diabetes can increase your risk also for heart disease in the future. And also, what is really impressive is that the impact of gestational diabetes is not limited to physical health. You would imagine that it would just focus on either heart disease or future type 2 diabetes, but there is evidence suggesting that a diagnosis of gestational diabetes during pregnancy can impact not only physical health, but also mental health. So that is another thing that's been reported by research. So as you can see here, we've got gestational diabetes and we've got a few conditions. I know there's a lot of jargon on this slide, so I'm just going to go through things briefly. We've got type 2 diabetes, we've got depression, we've got heart disease, we've got high blood pressure. So gestational diabetes increases the risk of all these conditions in the future. And that is why we need to think around gestational diabetes a bit differently. I'm going to move on to talk about what happens in the aftercare of gestational diabetes. I'm aware we don't have a lot of time, so I'm going to focus on the UK guidelines. So what we do in the UK after someone got diagnosed with gestational diabetes in pregnancy. One thing I want to mention is that a big problem we have in gestational diabetes, both research and clinical practice, is that there's no consistency. So different guidelines across the world recommend different screening tests, different ways of follow-up, different timelines. So it's very, very tricky to see a unified way of approaching these women because of this. And we're looking for a unified approach. So that's what we're trying to advocate for the future. In the UK, if you had gestational diabetes, you will be invited for a blood test. So after you give birth, you will be screened for type 2 diabetes or any other level of glucose intolerance preceding type 2 diabetes around 6 to 13 weeks after you give birth. And then if that test is normal, you'll get an annual test. So once every year, you'll continue to get tested. Also, women who had gestational diabetes during pregnancy are encouraged to have a healthier lifestyle. So they're encouraged to exercise, improve their diet, and also lose weight if that is needed. What you can see on the right-hand side of this slide is something that comes from a review I did a few years ago. So you have the classification of risk classification, which means how high or low is your risk of type 2 diabetes based on your screening test, based on the results that you get from your screening test in the UK, based on the UK guidelines. So we have two tests that you can see here. Again, I can discuss this later in the questions if someone's interested. So depending on the test result, you can be classified as moderate or high risk if it's normal. And then you get to receive the yearly test. But if you get these results that you can see on the right-hand side on this figure, you are diagnosed with type 2 diabetes, and then you are referred to further care. So this is the current recommendations in the UK. Well, there are recommendations for screening, and a lot of people are aware of them. What is a big problem is that we're not screening. So the rates of screening after women give birth with a history of gestational diabetes are extremely small. At this part of the talk, I'd like to mention something that is called health inequalities, and I think it's really important to mention every time we talk about health and disease, as not all members of a society have equal access to healthcare, and their health differs because of that. So health inequalities based on the NHS website are unfair and avoidable differences in health across the population and between different groups within society. And the reason why we can have health inequalities, there's several reasons actually. So a main reason is the lack of access. A lot of people live in remote areas. There's no services in these areas. They don't have often access to transport, access to childcare, and that can limit their opportunity to contact a clinician, to access healthcare, to monitor their health, and that can lead to worse health outcomes. Language and literacy plays a big role as well. People of lower language and literacy levels have worse health outcomes because of their experiences and interaction with healthcare. But also there's poor past experiences, misinformation and fear that can drive people to not access healthcare, and all these contribute to health inequalities. So how do health inequalities impact health? What does the data say? So these are data from the Office of National Statistics within the UK, where they investigated the gap in life expectancy between the most and the least deprived areas of England, and the results were shocking. So you have males and females living over 9 years more and over 7 years more for females between the most and the least deprived. So the people who were the least deprived lived over 9 years longer if they were male, and over 7 years longer if they were female. So this is how much they lose of their life expectancy, people who were born in the most deprived areas of England. So when doing this research, it is very important to consider this. And I'll get to talk about the findings on health inequalities later. Something I would like to mention, as this falls under the umbrella of women's health, and I identify as a women's health researcher in my research identity, we need to talk about why we need to be doing women's health research and why this is really important in 2025. So looking at the latest statistics, although there's so many people talking about women's health, identifying the gaps in current research, in 2020, the data suggested that only 5% of the global research and development funding is allocated to women's health research. And unfortunately, also the majority of that is not in the area of diabetes. It is actually in cancer. And again, I'm not saying that cancer is not important, but we need to be researching all women's health conditions. So very low percentages, even considering cancer, about for funding for women's health research. And then looking at the benefit of this, if this was changed, looking at the data from the World Economic Forum, we can see that closing the gender health gap would result in 1 trillion economic boost and change the lives of nearly 4 billion women across the world. So these numbers are huge. And this is why we're doing what we're doing. And this is why this is important. So if anyone's interested in looking into this further, there's some resources at the end of the slide if you want to look into these numbers and some other statistics. So now let's move on to what I do, and let's move on to how I do it first. So before we talk about the results, let's talk about the methods. So I will talk about what we call real-world data and what we call real-world evidence, because this is something we do as epidemiologists, and this is something that we need to talk about before we talk about the results. So real-world data are data about a patient's health status, so whether they're healthy or whether they have a disease, the delivery of healthcare, so for example, how we do screening, and they are collected from a lot of resources, for example, electronic health records. So this is what we personally use within our research group, and I'll talk about this in more detail later. So if we take this real-world data and we analyze them, we can generate real-world evidence. So it's clinical evidence about how we use a medical product, or, for example, how something is getting delivered within a healthcare setting. So analyzing real-world data, we generate real-world evidence, and then we can make recommendations about the way healthcare is being delivered in the UK as well as globally. So let's see this in a simple way. So each of us visits the GP here in the UK. When we go to the GP, they collect our data. So this data is being registered in an online system, and then this data is then anonymized and is provided for research purposes. If you go to a GP, the information they will usually collect is demographic characteristics. So for example, your ethnicity, your diagnosis or symptoms about diseases you've experienced or not, exposures to drugs. So if you were if you're receiving certain medication for a condition, your vaccination history, laboratory tests, so having a blood test is recorded, as well as referrals to hospitals and specialist care. So this information is being recorded, documented, and then anonymized and used for research purposes. So using the GP data, then we can also link to other sources. Now, from depending on the data set that you use, there's multiple linkage sources, so you can link to a lot of data sets. Again, being conscious of time, I'll only mention the data that I've used for the purpose of this project. So using GP data and also linking to the records of these patients to the hospital appointments, as well as their socioeconomic status or deprivation level. So having all this data helps us look at the disease from a wider perspective. We can consider different things, and we can analyze our data and make recommendations from a wider perspective as well, not just focusing on a single thing, but having a wider viewpoint about what's happening with these people's health. So now let's move on to the results, which is the exciting part. I'll just summarize the results of 3 projects, and then I'll get to talk about what this means for clinical practice. So the first project looked to see, and we've already mentioned that as this was the start of the talk, what is the risk of type 2 diabetes for a woman who has been diagnosed with gestational diabetes during pregnancy. And to do this research, I summarized data from published studies. For the researchers in the room, that was a systematic review and meta-analysis, where we combine information from published studies, and then we analyze the data and we make some recommendations. So this included 20 studies. We had over 1 million of women that were included. About 68,000 of them had gestational diabetes, and the rest of them were women without gestational diabetes in pregnancy, so not diagnosed with a condition. And this study found that women who had history of gestational diabetes or were diagnosed with gestational diabetes during pregnancy were almost 10 times more likely to develop type 2 diabetes in the future than those who were not diagnosed with a condition. So here you can see that women who have gestational diabetes have a very, very high risk of type 2 diabetes. And that was important because there was no recent evidence about this, and the only paper that looked to quantify this was from about a decade ago, and they found that women with a history of gestational diabetes were 7 times more likely. So this used more recent data, and we found that the risk is 10 times more likely. Now, the reason behind that is in line with some trends. So one is advanced maternal age, the fact that women are now giving birth at an older age, and that also is a risk factor for gestational diabetes, as well as the fact that there's increasing rates in obesity across the world. And again, obesity is a risk factor for gestational diabetes. The next research question this research looked to answer is how is screening for type 2 diabetes in the UK after being diagnosed with gestational diabetes. So we mentioned before that women who had gestational diabetes will be invited to get screened, but what happens in practice? So using contemporary data from GPs and hospitals, we saw that unfortunately less than a quarter of the women that were included in the study were screened on average once a year. So that was a study that included roughly 11,000 women across the UK, and less than a quarter of them got the annual screening test, the annual glucose screening test for type 2 diabetes. So this is extremely low compared to what we were expecting to see. There's some factors that are associated with a higher likelihood of being screened. So women who had some characteristics were more likely to be screened. And these were South Asian ethnicity, older age, a diagnosis of gestational diabetes, having a diagnosis of polycystic ovary syndrome, as well as receiving medication for gestational diabetes. Gestational diabetes can be treated with metformin or insulin. So having prescribed that medication for the condition, were all associated with being more likely to be screened. Now, this can be either because clinicians are more likely to invite people who have these characteristics to get screened for type 2 diabetes, as all these risk factors are risk factors for type 2 diabetes. So if someone, for example, is of older age, they're more likely to get diagnosed with type 2 diabetes. So a clinician will say, oh, maybe I should invite them for screening. And then the other reason is potentially women who had these risk factors probably thought it's more important to get screened. So they also acknowledged that it's more, they have a risk factor, so maybe I should get screened for this condition. So that's just thinking around what these numbers tell us about what is happening. And finally, the last research question we look to answer with this project is, what is the risk of developing health complications after a diagnosis of gestational diabetes? Now, looking back at the start of this talk, we talked about how gestational diabetes is associated with type 2, it's associated with heart disease, and also mental health complications. So using the same data that I mentioned before, I looked at a few conditions. These were type 2 diabetes, hypertension, and depression, and then found that there were differences by both ethnicity and deprivation. So looking at ethnicity, women who had gestational diabetes in pregnancy, who were from South Asian ethnicity, had a greater risk of developing type 2 diabetes compared to those who were of white ethnicity. And again, that is in line with what we observe in the literature in a general population that is at high risk of type 2 diabetes. People from South Asian backgrounds have a greater risk of being diagnosed with type 2 diabetes compared to those from a white background. Then women from black ethnicity who had gestational diabetes had a greater risk of being diagnosed with hypertension in the future compared to those who were of white ethnicity. And then again, that is in line with what we see in the general population. So not just women, but a general population at high risk of hypertension, high blood pressure. And then we also saw that both Black and South Asian ethnicity were found to be associated with a reduced risk of depression compared to white ethnicity. So women from Black and South Asian ethnicity were less likely to be diagnosed with depression. And then what we also saw was the risk of all conditions increased with increasing level of deprivation. So you can see here that this appears to be quite complicated, and this underlines potential health inequalities in this population, which makes us think about the way healthcare is being delivered. So we've talked about a lot of results, but what do these results mean other than being published? What do they do for clinical practice, and why do we do this research? So as I started saying, at the start of this talk, I mentioned that gestational diabetes is perceived as a temporary condition because of its nature. So having given birth, blood glucose levels return, blood sugar levels return back to normal. So you would assume that this is no longer a problem. But what happens in reality is that gestational diabetes seems to be an early warning sign about conditions that will develop in the future. So what we need to do is reconsider our perceptions, and instead of perceiving gestational diabetes as a temporary problem, understanding that gestational diabetes is a condition that has a long-term impact on maternal health and increases the risk of future health complications, and treating women with gestational diabetes keeping this in mind. So in terms of the life after gestational diabetes, there's a few things women who have been diagnosed can do. Screening is a main one. So being able to screen, to get screening frequently is very important. Type 2 diabetes does not develop overnight. So there's different stages of glucose intolerance, and being screened frequently can pick up something that is called pre-diabetes, so high blood glucose levels that are not yet type 2 diabetes before type 2 diabetes is diagnosed, and that is very beneficial because we can prevent type 2 diabetes. Also, what we can do is that even if someone is diagnosed with type 2 diabetes, being diagnosed early on prevents future complications and improves health in the long term. So the earlier you pick up a condition, the more likely you are to experience better health outcomes in the future. So the screening is extremely important. Also, changes to lifestyle. there's a lifestyle component to gestational diabetes, there's a lifestyle component to type 2 diabetes, following a healthy diet, introducing some physical activity. Again, this can be extremely challenging to someone who's just given birth, and that's the next thing we're going to talk about in the next slide. Breastfeeding has a lot of evidence in improving blood glucose or blood sugar levels following giving birth. So women who had gestational diabetes are encouraged to breastfeed, as it can improve, it can support losing weight in the postpartum, and also it improves blood glucose levels. And finally, education and support is extremely important. Here we have a population of women who have recently given birth. That is extremely challenging. A lot of these women have given birth for the first time. So once this happens, it's extremely difficult for them to look after themselves. So it's important that there is education and support to women who have experienced gestational diabetes, clinicians who are supporting these women, as well as the families of these women, so they can all support them together. So speaking about the challenges and speaking about this specific population, here we're dealing with something unique. We're dealing with women who have given birth, and a lot of them do not attend screening for very valid reasons. There was a very interesting paper a few years ago that looked at the reasons for not attending, as well as motivational factors for attending screening. So why women are not attending, and when are they more likely to attend screening? A few things they mentioned was, of course, adapting to life with the baby would prevent them from going to get screened. The logistics of attending the appointment, for example, being able to access childcare or support, also work responsibilities. But in terms of how they perceive the importance of testing, some women reported that they had poor understanding of the testing procedure, so they were not aware that they should be tested, how testing is being done, why it is important. And also some women mentioned that they had a fear of diagnosis. So avoiding screening would be also avoiding negative news. So they saw this as a way of avoiding this. So these things can often contribute to not attending screening. But we also had motivational factors, which is really encouraging, and it makes us think how we can plan this better and what recommendations can we make to improve this. So one thing that women pointed out as positive, which was something I had a discussion about earlier in a group I'm part of, that is a group from Diabetes UK, where we meet with, we are researchers meeting with clinicians and patients, and we all talk about gaps in research at the moment and how we can address them. Most patients mentioned that continuity of healthcare is something that is a priority for them, and unfortunately it's something that they don't experience. So continuity of healthcare means being seen by the same person, which doesn't happen very often. A lot of people report having a lack of access to, for example, specialist care, being able to be seen by the same person. In this study, women reported that they did not have access to the same clinician, and often the person who saw them didn't have their records, or it was very difficult to explain to them what was missing from their information. So having the opportunity to see the same clinician improves screening, and that is why more people would attend. So that's one thing to consider. Also, ability to understand diabetes risk. A lot of qualitative evidence from personal experiences of women suggests that they do not understand the risk of type 2 diabetes, or that is not mentioned to them. But others also mention that they are concerned about type 2 diabetes, and they want to know, so that makes them attend screening more. In terms of the statistics, more women lack the understanding of the diabetes risk that are aware of it. And that is something that has to do with how these women are managed. Currently, there's quite a lot of confusion whether this is something primary care, so GPs, or secondary care hospitals should be managing in the UK. And often these women don't receive information from anywhere else. A lot of people, usually it's people from higher language and literacy levels, are able to find their own information and be informed about the risk of type 2 diabetes, or they have a conversation with their clinicians. And then these are the people who are more likely to want to know what is happening and attend screening. So looking ahead, there's quite a lot of research that needs to be done, and this is exciting because there's loads of things we can do to make things better. So one thing is preconception. So preconception counseling, we need more research about this. We need more research in optimizing risk factors. So there's a lot of things that can increase your risk of gestational diabetes, and this can be prevented by planning pregnancy. So a lot of women are now following preconception care, but there needs to be more infrastructure to support that. So for example, if an individual needs to lose weight prior to getting pregnant, that will reduce the risk of being diagnosed with gestational diabetes and will reduce the risk of a future diagnosis of type 2 diabetes. So we need more research in the field of preconception. There's also early detection. So gestational diabetes is screened for in the second half of pregnancy, but there's more and more evidence supporting that we should be screening early on. We should be screening in the first trimester. So more and more later studies are suggesting that we need to be looking into this more, and that will probably be happening in a few years from now as standard clinical practice. So we're waiting for the evidence, but the evidence points out that there's benefits to screening women early on. In terms of the second and third trimester, there's currently no consensus about what is the optimal gestational weight gain. So how much weight should you be gaining during pregnancy? Because it's very difficult. Once you've gained that weight, you cannot lose it. So how do you manage your weight during pregnancy? And what should you do? Especially within a gestational diabetes framework, there's not enough evidence at the moment. And also reducing the intergenerational effect. So intergenerational effect means that if you had gestational diabetes during pregnancy, a lot of studies are suggesting that your future children will have a greater risk of obesity, experiencing obesity in later life, type 2 diabetes. If they're women, they can also have an increased risk of being diagnosed with gestational diabetes. So these genes are transferred from the mother to the children, and you have this continuous situation where we need to be looking into how we can reduce this effect. And finally, improving screening. As I mentioned today, as I've mentioned several times today, we need to improve screening. We need to be picking up individuals early on, and picking up individuals early on will improve their outcomes in later life. And finally, lifelong prevention of diabetes. So that would be type 2 diabetes, how we can actually prevent type 2 diabetes other than screening. What interventions can we introduce in these women's lifestyles so they can improve their health outcomes over time? Another thing I would like to briefly mention is what, after I say what this means and what we can do with it, I'd like to mention how I've spent some time translating the findings of this research into policy recommendations and what needs to be done that is currently not being done. So one thing we need to do that is currently not being done in the UK is have more community-based screening programs. So a lot of these women live in remote areas, as I mentioned before. They're less likely to attend healthcare appointments. They're less likely to be picked up as someone having type 2 diabetes. They're more likely to experience worse health outcomes. So community-based screening programs are extremely important for people who live in remote areas, and that extends beyond looking at gestational and type 2 diabetes. There's also a need for guidelines. So we need more guidelines recommending screening for physical and mental health related complications. Currently, if you look at the UK guidelines, there's a recommendation for screening for type 2 diabetes, but that's just about it. And that is not even being performed up to the standard that we would expect. So we need guidelines to recognize gestational diabetes as a pre-cardiovascular disease state, recognize how gestational diabetes also increases the risk of heart disease, and get more people to be screened for heart disease as well, be screened for example, depression, since there's an increasing evidence that suggests that. So high blood pressure as well, and that needs to be personalized by individual risk factors. We also need more interventions that can introduce sustainable lifestyle changes. That will be very challenging. Here we have, again, a group of people that have a lot of challenges in their lifestyle, so we need to find a way to reach them. There's the potential of technology, and there's a lot of studies suggesting that technology is a very efficient way. But again, we want to be thinking about technology without excluding people who will need it. So thinking around interventions, but also thinking that these interventions need to reach out everyone. These interventions need to be effective from two perspectives. So the one is health benefit for these people, but also being cost effective, which means that introducing them will save money from a healthcare system, given how much it costs to treat conditions like type 2 diabetes or heart disease every year. And that is something we also need to consider. A big part of these changes is also education. So we need to actively educate healthcare professionals about what it means to have a diagnosis of gestational diabetes and how this elevates your future risk of type 2 diabetes, how they speak to these women. And at this point, it's very important to mention that we need to consider language, and healthcare professionals should be educated to use language that can be understood by these individuals and have multiple ways of approaching them. Finally, we need to support community programs providing education to women as well as their families. So again, as I said before, this is a very challenging time for women who've just given birth. They have all these responsibilities of having recently become mothers. This is something that is particularly challenging, and they will need all the support they can get. So having community programs providing education that everyone can access is particularly important in this population. If anyone's interested more about policy, this is something I'm particularly keen on and I spend a lot of time doing. I've been to the parliament a couple of times before, and I've spoken to a few MPs about the importance of introducing changes in the healthcare system at the moment based on the findings of this research, which are also summarized in a policy briefing that is intended for a non-specialist audience. So if anyone's interested in looking at this, you can also have a look at the university website where you can find it. And I'd like to thank you very much for your attention. I know this has been a relatively long talk. I hope I've covered most of the areas you were interested in, but if anyone wants to talk about this in further, these are my contact details. So this is my email and LinkedIn account. I'm also based at the University of Leicester, so hopefully I'll be meeting some of you if you're around, and I'm happy to stay for questions and have a chat with you about anything you're interested in. Thank you.
Wow, that was an amazing talk. Thank you so much. I've learned so much, and you've covered so many different perspectives of this disorder. So I think that's a brilliant overview. I'd just like to thank you to everybody for listening and for submitting some questions. Please continue to submit some questions. If we don't have time this evening, then I'm sure we can answer them post-talk. For anyone who's joined that little bit later on in the talk, don't forget that we are recording this, so you can catch up with the talk via the recording. So let's go on to our first question, and I think this has been asked in different ways by a couple of people listening. So I'll just take one version of this question, which is, without wishing to apportion blame, how much can you say gestational diabetes is caused by a patient's lifestyle choices and environment, and how much by genetics?
Okay, that's a very interesting one. So it is very difficult to communicate this, and it's very difficult, especially to someone who's pregnant, to say that, for example, you have a diagnosis of gestational diabetes, and that might be because of your weight, and you should be very careful about how you phrase things. And often what I've found out through discussions with people who have experiences from healthcare is that this is not communicated in the best way, and that can lead to the other way around, like someone completely dismissing healthcare because of the way they're being spoken to. And that is something that I'm hoping by the things I've mentioned will change. So there's some modifiable and non-modifiable risk factors. For example, weight is a modifiable one. It is a risk factor again. Some of these are non-modifiable, so there's the impact of ethnicity, there's the impact of age, for example, that you cannot modify. But again, because of the latest research, there's recommendations for screening earlier in pregnancy, so that might be able to pick up things early on. And even if you're diagnosed with gestational diabetes, if there's one thing that I hope comes out of this talk, is that the only thing that will, if anything, this is something positive, because rather than receiving a diagnosis of type 2 diabetes out of the blue, you get a diagnosis of gestational diabetes in an average age, for example, of 30, where you're more healthy and you have time to intervene. And if you do intervene, you might never get diagnosed with type 2 diabetes. So there's plenty of opportunity to do that. So if anything, I would like this to be seen as an opportunity to improve health in the future.
Yeah, I think that's a really big one, isn't it? With the whole kind of language around pregnancy, you have to be so careful. I remember I had my son when I was that little bit older, and you're termed as a geriatric mother, and I do think the medical profession needs to kind of revisit some of the language used. So it's really interesting when you say, when you're approaching issues of weight or age, that you have to be mindful of communicating that properly. And yeah, I mean, early screening for any kind of health issues is just so key, isn't it? And it's so interesting to see that your research is pushing that in Parliament. Just fantastic. We have another question, which is, at what stage in pregnancy does gestational diabetes develop, or does it vary? Is there an average time frame between the diagnosis of diabetes and the onset of pre-diabetes or type 2?
So there's quite a lot of information here. Gestational diabetes is screened in the second trimester between 24 to 28 weeks of gestation. So that's around the time they do screen, and that's what's recommended in the guidelines at the moment. So most women are picked up around that time. But there's recent evidence suggesting that this condition starts earlier in pregnancy and we should be screening earlier. There's also other things, unfortunately. One thing is that, for example, someone had gestational diabetes in a previous pregnancy, then they don't get screened for a while, they reach second trimester, and they might be misclassified, misdiagnosed as gestational diabetes, and they're probably pre-existing type 2 that has developed from their previous pregnancy with gestational diabetes. So there's quite a lot of nuances like that at the moment. And that is why there's a lot of research in the field. We're trying to understand the exact timelines of when things happen and what we can do to pick up people earlier, because there's a lot of misdiagnosis, misclassification at the moment. So hopefully in the future, there will be more information. In terms of when type 2 diabetes develops, it can really vary. Like, there's a lot of studies suggesting different things. It really varies on the individual risk factors of the patient. So some people will get diagnosed very early, like after their gestational diabetes diagnosis. Some people will not get diagnosed at all. And it really varies by individualized risk factors. So that's something that's also being investigated at the moment, the exact time that this happens.
Got you. Thank you. That's really interesting. So it can be from a previous pregnancy, so you never quite know. We've got another really interesting question from one of our viewers, which is there any evidence to suggest that women who have gestational diabetes are more likely to have children who have other disorders? And the person who submitted this question has said, one of my children has PCOS and one an underactive thyroid. Is gestational diabetes linked to premature birth and consequently health challenges in that child? And before we started this talk, actually, I was looking at some videos and there was a suggestion of a link between gestational diabetes and autism. So I just wondered if your research is kind of heading in that way.
So far I've focused on, that's a very interesting question, and it's something I've I'd like to look at in the future, actually. But so far, what I've done is on maternal health. So I've not actually produced any papers myself that are looking at offspring outcomes. That can be a bit challenging at the moment because we're using data from data sets, and it's very difficult to find and match mothers to babies and have enough follow-up for this to happen. So that is being done. I know there's several studies from the United States that have looked into that. And there's a clear pathway between, as I mentioned before, obesity, type 2 diabetes, elevated lipids. So anything metabolic is clearly associated. In terms of PCOS, I'm not aware of any studies, but now I'm interested, so I'll look into this after this talk is over. So that's another thing to consider. This offspring outcome. So other than maternal health, also gestational diabetes impacts offspring outcomes. So you get large for gestational age. Women with gestational diabetes very often have very large babies, and that's because of the elevated blood glucose or blood sugar levels. You get increased risk of premature birth, stillbirth. So all these outcomes can happen in the infants as well, and that can lead to other unfavorable health outcomes, obviously, as you have a complicated birth and your offspring experiences side effects. You can get other health outcomes as well, which is really something to look in the future. I'm hoping that I'm very interested in the intergenerational transmission of disease, and that's something I'd like to look at in the future from a genetic perspective, because at the moment I'm just looking at traditional risk factors based on history.
That's really interesting. There seems to be a lot of medical fields at the moment that are looking at intergenerational, whether it's trauma or something like this and how it affects ongoing generations. So yeah, really interesting that you're going down that road as well as all your other roads of research. We've got another really interesting question, which is there also a higher risk of developing type 1 diabetes for women who have previously had gestational diabetes? Also, on the back of that question, somebody's asked, and I'm really interested in this because you spoke about AI and the scanning process getting better. Is gestational diabetes screening dangerous, uncomfortable? How does it actually work? So how do you screen, and how do you screen and what do you see?
So a few questions in that question. The first one was about type 1 diabetes. So type 1 compared to type 2 gets diagnosed early on, and the way it's screened is that it has a genetic component, so you can look for specific things. And that is something that you usually get in a younger age, so you wouldn't normally get that. But there are some women, surprisingly, that get diagnosed with gestational diabetes and then get diagnosed with type 1 as well. They're not the majority, but it also happens. The majority is type 2 because there's a clear similar background that contributes to the disease. In terms of machine learning, what was the question that was asked specifically?
I think that was about the scanning.
Oh, sorry,
Scanning
for the
process.
screening for, yeah. So for the screening for gestational diabetes, unfortunately, for people who are pregnant, who have been pregnant in this chat, they've probably had this test before. That is very uncomfortable. It's called the oral glucose tolerance test, where you have to ingest a liquid that tastes awful and causes nausea, is how people that I'm friends with have described it. And then you have to wait and see the outcomes about an hour or 2 hours later. So a lot of women are put off by it, unfortunately, and it's a very uncomfortable experience. I've worked in Greece before. So in Greece, in the postpartum, so after you give birth, they use that test. And I had this problem when I was doing my master's research, that I couldn't recruit women because they wouldn't come back for this test.
Oh,
Fortunately,
no.
in the UK, we do other tests. We do the fasting plasma glucose, which is your blood sugar levels when you've not eaten in the morning, and the HbA1c, which is the average of your blood sugar levels in the last few months. So fortunately, in the UK, that is not being done. But then during pregnancy, the gold standard test, it's still this oral glucose tolerance test that is unfortunately very uncomfortable.
Oh no, oh dear. So like you say, that's going to put women off taking it, but if more can do that, then obviously you've got more research. Yeah, no, that's interesting. Thank you so much to everybody for some really interesting questions. That's been a really nice end to the talk. So yeah, I'd just like to thank Elpida again for a fantastic lecture. It was really, really interesting. And thank you to everybody for joining us this evening. If you do have a spare moment, if you could look at our feedback form, if you could take a moment to fill out the post-event evaluation form, which is in the chat. The link for that is in the chat. That would be brilliant. We really appreciate that. If you want to stay updated on alumni news and up and coming events, then please check that your contact details are up to date by following another link in the chat. And then if you want to stay connected with us as part of our highly valued alumni family, then please keep following us on Facebook and Instagram, and visit our website for future events and future online talks like this for the Festival of Change events. I'd like to thank Elpida again. It's been fantastic talking to you this evening. Have you got any final comments for your audience?
I'd just like to say thank you to everyone for joining, and yeah, hopefully we'll be in touch over future events, or if you're based at the University of Leicester, hopefully I'll see you somewhere. And thank you again. If you would like to reach out to me, I've left my contact details on the last slide. So yeah, please do if you're interested in all this. Thank you.
Oh, brilliant. Thank you so much for taking the time to speak to us, and goodbye everybody, and keep in touch.